officially on air now.
It says I'm live on air. Hello. Hello. I have no idea. Well, who knows? Have you tweeted it out yet? Because then I will retweet it and then I will start talking for real. Although I suppose people could be watching right now.
That's true.
The magic of the internet. Oh no, that's not it.
So Mark, but yeah, he's trying to see. I see you.
You can see me?
Yeah.
That's exciting. You can see me in so many ways. Here and here and yeah. You haven't actually tweeted it yet, have you?
Just for a second.
Oh, there it is. All right, I'm retweeting it, and then I'm going to assume it's real. I've retweeted it. It's very exciting. All right. We're assuming so many people are watching at this point. Welcome to Healthcare Triage Live. We're going to be trying to answer some of your questions live, all the 4, 5, 6 people watching at the moment. We have some questions which we have received before in the past, and we'll have a list of those and we'll go through those. Other questions, please put in the comments right now. Any questions that you put in the comments or anything you say in the comments is almost guaranteed to be read live on the internet because I have nothing else in front of me to talk about. So we're joined by Mark and Stan, and this is an experiment. We've not tried this before. It's brand new technology in the office. There's a box here which magically I think does this, as opposed to, with the cameras and everything else. And I think I've dawdled enough to give you all a chance to start watching. I'm going to try answering some questions. So let me find that. Here we go. The first question we'd received was, thoughts on provider status for pharmacists? Well, that's from Farm Nerd Matt, and it's not actually grammatically correct, but I'm going to answer it anyway. If you're asking me if pharmacists should be allowed to practice without a doctor's supervision, I imagine there's probably some things they could do just fine. I mean, for the use of over-the-counter medications or even for probably prescriptions for very simple things, I imagine it would be okay. But for the use of anything which requires a physical exam or something which might be outside the scope of a pharmacist, then I'm not sure if provider status can be given. I mean, you imagine that even something like the diagnosis of strep throat could theoretically require some level of mid-level practitioner to do it first to make the diagnosis, at which point a pharmacist could certainly write the prescription, but I think that, probably they would need some extra training before then. We have a question from Nivek1234. Is there any research about what the recommended fluid intake should be? And that's an excellent question. So one of the first myths we ever talked about in our book, in our original paper on medical myths, was the idea that you need 8 glasses of water a day. And for that came out of a recommendation published in like the 40s and 50s by like a nutrition council in the United States. And if you go back and you look at it, it says that they think human beings need about 64 ounces of fluid a day. And there wasn't a lot of good science behind that. It was minimal. But they had at least some idea of what they were talking about. But there's a comma. And then it says, but the average person is going to get that through their normal diet. Because, of course, there's water in juice. There's water in tea. There's water in coffee. There's water in beer. And if you consume those things, you're going to get water. If you eat vegetables or fruits, you're going to get water. There's water in almost everything we eat, and normal people who eat a well-balanced diet get more than enough fluid and probably even get the 64 ounces that they require a day. There is no magic number of pure water that you need a day. In fact, the human body doesn't know where that H2O molecule came from once it's inside your body, whether it's a glass of pure water or whether it came inside fruit or any other type of beverage. Now, of course, a small woman living in a humid tropical zone does not need the same amount of hydration a day as an obese man living in the desert. So there are going to be variations. And there is no sort of good recommendation for, what each type of person needs where. But, evolutionarily, you're incredibly well designed to regulate your hydration. And, when you're thirsty, contrary to what you might have read, that doesn't mean you're dehydrated. It's the very beginnings of edge of your body. You might need to drink something. So if you're thirsty, by all means have a drink. But if you're not, there's no need to force extra fluid into your body. You're not doing anything other than creating extra urine. Okay, we've got Bob Longmire 1, who asks me, does microwaving food make it less safe? Are there any studies showing it's safe? And the answer to that is well, first, the answer to the first question is no. Microwaving absolutely does not make food less safe. In fact, there's not a lot of good evidence that says that microwaving food would even make it less unhealthy. Microwaving is non-ionizing radiation. It's not the kind of radiation that messes with your DNA or can cause damage to your body. It basically heats up water molecules in food. That's what it's doing. It's more akin to radio waves than it is to the type of radiation you think about in X-rays. And that's what it's doing. It's heating up the water molecules in food and making it hotter. It's not necessarily breaking anything down or changing chemical composition, certainly not making it any less safe, let alone even less nutritious. So I wouldn't worry about it at all. And microwaves, even if they do leak a little bit of radiation, as I said before, it's non-ionizing radiation. It's not the kind you'd worry about that would give you cancer or do anything bad.
Stephen Full wants to know about Apple's research kit and how it will affect healthcare research.
Apple, oh, that's a great question. So I think we even have a healthcare triage video on that. So if you didn't hear, Mark was saying that, what was his name?
Stephen Full. Stephen
Full was asking, whether Apple's new HealthKit and their new announcements will change the way that we do research or do anything else. Did we just lose everything? We're off. Oh, okay. Oh, there we are. We're back. Excellent. Whee! Welcome back to Healthcare Triage. So the question was whether Apple's new announcements about HealthKit or their new research will change anything. So first of all, we actually have a Healthcare Triage video on this where I talked about their announcements way back when they talked about HealthKit when it was first announced, and why I'm very skeptical that it will lead to any significant changes in healthcare. Mostly because we focus too much in HIT on the technology and not enough on people. And there's a lot of theory and a lot of evidence that shows that changing the technology is not nearly as important as changing behavior. And changing people's behavior is so much harder than technology. Just giving people information, just recording it is not enough to improve health. So from that end, I'm skeptical. For the collection of data from research, look, I love Apple. I'm ordering my Apple Watch the second it comes out. I own a ridiculous number of computers. We got a Mac right here. I own multiple iPads. Here's my iPhone. I still don't think this is going to change the way that we do research, because we've had the ability to collect data through web technology and the internet, and even using phones for years. In fact, I've helped write software and do stuff to do that work. The problem is always compliance, and it's how do we get people to actually enter the information we need and consistently do it. That is so much harder than the technology links to collect it. And the idea that somehow just all of a sudden providing a new bell or whistle to collect the data is going to overcome that problem is somewhat naive. Moreover, a lot of times the patients that we want to collect the data from, the patients that we need the most in trials, are not the people who are frequent users of iPhones or the ones who are massive users of information technology. When we're looking at the very sick, the very poor, the elderly, these are not Apple's core demographic. And so while I'm hopeful, and I'd love to see all of this work, and if Apple wants to send us free technology so that I can test it out, feel free. I'd love to get it. But I just don't think that without a lot of solid work behind it that is going to move the bar very much.
I'll give you this.
Okay. Ooh, it's a bag of Soylent.
James asks what your thoughts are on Soylent and other full-time meal replacement products.
I can't believe there was an actual question on Soylent.
Yeah,
this has been an ongoing debate in the healthcare or the DFTBA offices here and among the people that make healthcare triage. So if I'm not betraying Mark here, he's been actually eating this stuff. This is Soylent, which I imagine is a playoff of Soylent Green, which is made out of people. But it's supposed to be a replacement for eating. So if you eat this whole bag of Soylent in the course of a day, basically it's a powder to make 3 glasses of liquid fluid consumption a day, and you're supposed to add oil. It theoretically gives you all a body needs. You get all the carbohydrates, all the fat, all the protein that you might need in a nice handy bag. It costs like $10 a day. How do I feel about this? I don't think it's dangerous. I think it's probably adequate towards getting the nutrition that you need. However, I don't believe this is living. I don't understand why people have so much trouble eating food, which is delicious. And if, you can do this, I guess if you truly hate eating so much that you'd like it reduced to its bare minimum necessities of putting, powder in a glass and stirring it up with water so that you don't die from malnutrition, Soylent may be for you. If, however, you like the taste and camaraderie of a well-prepared and tasty meal, I don't understand anyone who eats Soylent, and I don't get it. But I don't think it's dangerous at all, and I think probably eating it. Now, Mark has brought up a good point to me in the past, that if we could distribute bags of this stuff for a very low amount of money to areas that are very low resourced and people are starving, that it's a good solution to get people the calories and nutrients they need that they might otherwise not be getting. I endorse that. That makes total sense to me. But these bags cost like $10 each, so that's not the solution that necessarily we're looking for at the way it's being marketed right now. And so I think it needs a little bit of work on its business model if that's where they're going for. All right, our next question comes from Austin Frack, the guy I write my blog with. He asks, are doctors overpaid? So not as overpaid as economists are, obviously. So am I overpaid? Of course I'm not overpaid. Are other doctors overpaid? That's a complicated question. How do we define overpaid, especially in the United States of America? If we want to say compared to the rest of what people do, doctors do make up a greater percent of the top 1% of earners in the United States than any other profession. So we make a fairly large amount of money. Doctors also make more compared to other citizens in this country than in almost any other country we'd compare ourselves to. So the ratio of what a doctor makes in almost any other country in the developed world versus regular citizens is actually, their salaries are closer together than doctors are to regular other citizens in the United States as well. There's a big difference, however, between subspecialists and generalists. Subspecialists make significantly more than do generalists, so there's an argument to be made that perhaps their salaries could come down. Some doctors in the United States, especially like family physicians and maybe pediatricians, could actually stand to make a bit more compared to other countries. So if everything was made fair, there might be a little bit of regression towards the mean. But I know Austin's asking this just so I can say that I'm overpaid. I will not do that.
It's a good thing that Burger King replaced soda with milk at kids' meals.
Wow. So what was his name? Kyle Moore asks if it's a good thing that Burger King has now replaced soda with milk in their kids' meals. Well, if you watch this show at all, you know my hatred for the milk emperor. So, God, this is a toughie. Okay, so if we're replacing like sugar soda with milk, milk is probably better. I'm gonna say that because at least it's more protein based. It's a little more satiating. It's not added sugars. That might be a bit more healthy than pure sugar, especially in a large soda where you're going to get a ton of calories. So probably. However, if it's diet soda versus milk, I don't know. I don't know if kids even need the added extra calories they're getting from, milk, which is still not zero. It can be, 3 8-ounce glasses of milk a day could be 250 calories, even of non-fat milk. Diet soda is 0 calories. And as we've done on another episode of HealthKit Triage, that the dangers of artificial sweeteners are vastly overblown. There's no good evidence that that's real at all. So I don't know that I would rather see, kids be drinking milk rather than diet soda. That's a fair toss-up. Now, I know a lot of people get angry at me for that or would disagree with me for that, but I don't know. Having said that, of course, eating Happy Meals or meals from Burger King entirely is of questionable nutrient content compared to sort of a home-prepared meal. So I'd rather say have a meal prepared at home, perhaps not as high in fat, perhaps more laden with protein, perhaps a little bit more vegetables and fruit than you'd likely see in a Burger King meal in general. So perhaps this is just the wrong question. Not that I fault you for asking that question. All right, we've got next. Yes, I think. Yeah, am I missing? Amanda Cook. Okay, I see Amanda Cook has asked about chiropractic care. Is there evidence for benefit? It seemed to help me a ton during pregnancy, but it might have been placebo, which is fine by her. Well, then I go, okay, look, if you're fine with the placebo effect and you don't care about the cost, far be it from me to destroy that from you. So sure, go ahead and get it and turn off your computer now so you don't hear the rest of my answer. But for the rest of you, there's no proven benefit to chiropractic care. There have been good systematic reviews and randomized controlled trials of this for a number of different things, back pain and everything else. The problem is it's very hard to do placebo-controlled trials. I mean, what is placebo chiropractic care? But when they do it, when they figure out ways to try to add it, it turns out that there's just not a lot of evidence to support it. Insurance rarely covers it, and I'm not even arguing that it should, because of course without benefit, why are we doing it? Why should insurance cover it? And there's always a tiny risk of harm, and it is tiny. I mean, most chiropractors aren't going to hurt you, but a lot of the benefits are anecdotal and they're vastly overblown. There's just not a lot of good evidence for it. Having said that, it's your money. And this is, most countries where this is broadcasting, it's your money, you're free to do whatever you like. And if you want to pay for chiropractic care, and if you're feeling like you're getting a benefit from it, even if it's from placebo, I'm not going to take that away from you. I'm not going to tell you never to go do it. However, if you're not, totally loaded with cash and have a ton of disposable income, there are probably far better things that you could spend your money on than to continue to do so with chiropractic care, as there really is no proven benefit. Do we have another question here? Oh, James Sasek. James Sasek asks, oh no, he was the one that asked about Soylent. So which question am I missing? I don't see that.
Sorry. Research talked about, nobody asks, is there any hope for rural health? I don't know. That's what research never did.
M. Havery asks about rural health. Is there any hope? He lives in the mountains and he's worried about that. And he wants research grants and everything else. So is there hope? Sure. Technology is always improving. So we have two problems here. One is that we don't necessarily have a doctor shortage in the United States, even though we say that all the time, is that we have a maldistribution. We have too many doctors in some areas and too few doctors in other areas, and too few other level providers in some areas and too few in other areas. And it's hard to fix that in a world that's free, because we can't make doctors go or make nurse practitioners or other mid-level practitioners. We can't force them to go practice in rural areas. This leaves a number of rural areas without doctors. Here we live in Indiana, and almost all of the subspecialists, at least in pediatrics, are really centralized in Indiana, and people have to travel a fairly large distance to go see a pediatric endocrinologist, a pediatric gastroenterologist. That's a problem. There's a lot of potential, though, in things like telemedicine and distance medicine and trying to care for people from further away. That's the kind of technology that Apple wants to break into, as we discussed earlier. It just hasn't worked yet. Pay for it. We haven't figured out how to organize it. And of course, there are some things that you just can't do by distance. Sometimes you actually have to lay hands on a patient and actually make a diagnosis by looking at them or feeling them, or, well, that sounded terrible, but doing a physical exam, or finding something that you otherwise couldn't. And so I do think that there's real potential to improve the way that we do rural health. But until we can come up with a better distribution of our providers, there's still going to be disparities between what you can get in a rural environment and what you can get in an urban environment. Our next question comes from Ricky Rampula, who's watching, who asks, is there a benefit for probiotics when taking antibiotics for prevention or treatment of C. diff infection? So we actually talked about this in a recent question video that I did with John. And so I encourage you to go watch those. Those are very, very entertaining as well. There are some good studies that show that probiotics, even in randomized controlled trials, can have a benefit in sort of overcoming diarrhea from things like having taken antibiotics, because your gut is full of all kinds of bacteria, and some of them are good and some of them are bad. And it's a nice balance, and enough good bacteria prevent the bad bacteria from sort of overtaking things and becoming too prevalent. When you take antibiotics, often what can happen is you can kill off the good bacteria, which leaves the bad bacteria a real chance to thrive. And that sometimes happens when you can get post-antibiotic diarrhea, is that you get an infection from something like C. difficile, which Ricky is asking about, where that starts to overgrow because you've killed off the good bacteria, which is a real good reason not to overtake antibiotics, by the way. And probiotics, which sort of reinfect your gut with the good stuff, are ways to try to get rid of that. And as I said before, there is some evidence that for some things probiotics do work. There's a decent amount of evidence for diarrhea after antibiotics to work. There's some evidence that things like for prevention of eczema or other atopic disease, it does an okay job. And some other things it's just totally not proven for. But probiotics are one of those things where, unlike chiropractic care, there is some good evidence. And so in certain situations, you will find doctors recommending it, and I think that they have a leg to stand on based upon what we've seen in the literature. All right, we'll try one or two more questions, I think, here. Let's see. Ben Mo, M-O-O-E, asks, hey, you're a doctor. Can you take a look at this rash? No, I can't. Okay, so DHJ She asks, why are mental services so hard to get? Okay, that's a great question. So in the past, it was often that it was difficult to pay for them, that insurance wouldn't cover them. We had a very skewed, almost bigoted way of looking at things, that physical disease was something insurance had to pay for, but mental disease, not so much. That's changed. A lot of mental health parity laws have been passed. The ACA sort of cements this. And so it is much easier to get mental health services paid for. Having said that, getting the referrals can sometimes be difficult, and we do have a shortage of mental health care providers as well. And they are, like with other providers, skewed heavily towards urban areas. So it is often difficult to get appointments just because we don't have as many practitioners to sort of overcome the need. I've always felt, if I had my way, I think, therapy should be as common as well checkups. I think everybody could almost benefit from it. But we have it distributed in such a way that we think physical health checkups are a necessity, even with no proven evidence. But mental health checkups are just craziness. And we don't do that. I think that that's a real mistake. I wish there was a way to fix that. Why don't we take one more question here? I won't do AFRACT again because he had one. Let's try. The nudie asks, why have we not found a reliable way to turn off pain yet? Well, we have reliable ways to turn off pain. The problem is that it turns off all other sensation as well. I can give you an epidural, I can give you a shot of Novocaine. I can absolutely remove your pain, but you can't feel anything. And often your muscles won't work then. And so that's a problem. It's not that I don't know how to overcome your pain completely. It's that I know how the only way to do it is also going to turn off your nerves completely. And we need nerves. You need, pain serves a function. It tells you when you're in danger. It tells you when you need to pull your hand away from that hot stove, because otherwise you'll burn yourself. And if I remove all pain, I've removed your ability to function in a normal environment and prevent injury and also know when things are going on. You need that tactile sensation. And unfortunately, the difference between tactile stimulation that's pressure almost getting to pain, it's subtle. And we're not very good at removing one without removing the other. And you need that really to function in society. So I think we should stop there. I want to thank everybody that participated in this. We're excited that it's worked out this well. We know now behind the scenes information, we tape Healthcare Triage almost always on Wednesdays. That's when we do news for Friday. It's also when we tape our regular episodes to be batched on future Mondays. So I think we're going to continue to try to do this on Wednesdays, depending upon when we film, usually in the morning. We'll try to update information by Twitter and other means to keep people informed about when we might do this. But if you find this of value, spread the word. We're going to keep answering your questions live on the air, and then probably put these videos up for consumption afterwards for people that want to go back and watch them in not real-time asynchronously. So again, thanks for tuning in. We'll see you on Friday for Healthcare Triage News. Where's my thing to hang up? I can't find it. We're going to hang up. I'm going to. Here we go. Oh, there it is. And hanging up. There we go. And